We use the tests, I think, in two different ways. One is in the adjuvant setting where there's a question about whether or not chemotherapy will provide benefit for a patient. The second sometimes is when the markers aren't concordant. You have a low-grade tumor, but it's hormone receptor negative, and you really want to see whether or not that's an error of immunohistochemistry. Or you have a high-grade tumor that's strongly estrogen and progesterone receptor positive. You have a tumor which seems like it shouldn't have positive nodes, but you have a small amount of disease in one lymph node. We tend to only use the tests in node-positive disease when there are 1 to 3 positive nodes, and usually a relatively small volume of cancer in the nodes. And I found it very useful in that setting. The other situation where we might use a genomic tool, and in fact we standardly use it at our institution because it's embedded into a large multi-center clinical trial, is in order to decide which patients might benefit from chemotherapy in the neoadjuvant setting versus hormone therapy alone or going straight to surgery. The Oncotype DX assay, or the Recurrence Score, is a test looking at gene expression in paraffin-embedded tumor. And you don't need very much tumor to do this. We send off a small amount of tumor, or you can send off the block, which will be returned from either a core biopsy or from the tumor resection. We don't send it on the axillary node because the test was validated on the primary tumor, so it would only be sent on the axillary node if there was no tumor sample available or there was a question regarding discordance and after discussion with Genomic Health. The test actually looks at gene expression, so not DNA like you look at with FISH testing for HER2, and not protein like you look at with immunohistochemistry, but you're actually looking at gene expression of 16 cancer-related genes and 5 reference genes that tell you that you have adequate amounts of messenger RNA. The 16 cancer-related genes are grouped mostly into genes that actually tell us about specific factors like the hormone receptors, HER2, proliferation, invasion, and then there are 3 additional genes that give us information about the relative aggressiveness of the cancer. And what that does actually is translate into telling us about 2 different factors. One is the prognosis of the cancer, and to truly understand the prognosis, you have to include clinical and pathologic variables like the tumor size, the age of the patient, and the tumor grade, all of which help a little bit in determining prognosis. The second thing, and the most important, I think, factor that we get information about from the Recurrence Score, Oncotype DX, is predicting benefit of chemotherapy and, to some degree, benefit of hormone therapy. What you get actually from the Oncotype DX Recurrence Score is a 3-page report that gives you the recurrence score data and how that translates an ER-positive, node-negative disease within a 95% confidence interval into the risk of distant recurrence. And that tells you another important difference between these online non-individualized predictor tests. What that is that it's only distant recurrence. So as for medical oncologists, what we care about in terms of prescribing mostly chemotherapy and to some degree hormone therapy is the risk of distant recurrence, because that's what translates into mortality from breast cancer. We're not treating as much in most situations for the risk of local recurrence, and we don't use chemotherapy to reduce local recurrence risk, although it has an effect on that risk as well. So what you find out on that first page is in a sort of continuous score, the score that your patient's tumor has and what that correlates to in terms of risk of distant recurrence, as well as a 95% confidence interval. The second page actually puts that into the data that we have, the validated data. And if it's a node-positive patient, it will put it into the data that we have from the intergroup study that Kathy Albane has published, within the caveats that this is a smaller population than the total trial, and it involves anthracycline chemo versus not. For node-negative cancer, where the test is most commonly used, it gives you information from NSABP-B20 in terms of what the observed benefit from the addition of chemotherapy to 5 years of tamoxifen was, again with 95% confidence intervals for the low, intermediate, and high-risk disease, both in a bar graph and in another graph form with the continuous variable. Then the third page actually gives you the single gene scores for estrogen receptor, progesterone receptor, and HER2, and tells you positive or negative for ER and PR, so you can correlate it with your immunohistochemistry results. And then it also gives you for HER2 negative, positive, and an indeterminate range. And that helps a little bit when there's discordance with the HER2 testing done by IHC or FISH. The recurrence score actually is very complementary, so it adds information. And as we were discussing earlier, a lot of the factors that we have give us information about prognosis. And then ER and HER2 give us also predictive information, but in a very heterogeneous sense in terms of ER. So what the recurrence score does is it adds and complements those standard markers and information that we obtain from patients. In terms of prognosis, we take those standard markers and the patient factors, and we add the recurrence score together to try and better understand prognosis. For example, if you have a low score but a very large tumor, you're going to have a slightly higher risk of recurrence than if you have a low score in a very small tumor. If you're older, that may represent a slightly different risk than if you're very young, and particularly if the difference is striking between the very old and very young. The same is true for grade, where it may impact a little bit in terms of prognosis. The prediction of benefit is an independent addition to those factors that we already know, and it gives us information that is independent of tumor size, age, hormone receptors, etc. The recurrence score, I think, has its greatest utility in situations where we have a question about whether chemotherapy will provide benefit. Either we've decided to give chemotherapy, but we have a little insecurity about it, or the patient doesn't want to receive chemotherapy and feels quite strongly, or it's a situation where we would normally give hormone therapy, but we still have some uncertainty regarding the benefit of chemotherapy. So the indication is clearly an ER-positive, node-negative breast cancer, but in a patient for whom chemotherapy is possible. So I don't think in a 95-year-old you're going to be sending the recurrence score if you're not going to, if you already know you can't give chemotherapy, it's not going to be as beneficial, and so there's no point in sending the test. The other situation other than ER-positive node-negative disease is ER-positive node-positive disease. We were talking about a little bit earlier where there might be 1 to 3 positive nodes. Usually there's a small volume of node disease, and these patients have lower risk features, ER-positive lower grade tumors. If you had, for example, a 35-year-old with a positive node, ER-positive high-grade histology, it's going to be pretty hard not to give chemotherapy, so the test is less useful. But a situation where you have a small tumor, low grade, strongly ER/PR positive, and a disease in one node, you may be thinking this patient may be better treated with hormone therapy. And for a younger woman with ovarian suppression and hormone therapy, we have good data to back up efficacy of this treatment in that population. You could avoid chemotherapy, and a recurrence score may be very beneficial in that situation. It's an interesting question. So is it, if you have more information, does it make it more difficult? And I've found it just the reverse. When we're sort of floating out there with a sea of lack of information, patients feel lost. Many times, I think that, we find patients fall into two broad categories. Patients who really want the doctor to tell them what to do, but they also want to feel secure that you know what you're talking about and that you feel secure in that recommendation. The second is where the patient really wants to be a partner in the decision-making process, and I find that that's more and more common and represents the majority of our patients. They really want to understand the risk versus benefit ratio, and we can't provide that for them without understanding the most possible information about the biology of the cancer and the chances that the cancer will respond to chemotherapy as well as hormone therapy. So what I do actually with the recurrence score information when it's at all possible is I have the patient in the office and I actually show them their recurrence score information in color on the computer screen, since we're generally printing it in black and white. And then I'll try and give them more information through that about what their potential benefit is from chemotherapy and put it in the context of the risks and the recovery time. And I find that that is enormously helpful for patients. And indeed, they may not be able to repeat it all afterwards, but I think they just feel much more secure seeing that information and understanding what the information that their cancer can provide is, as opposed to a group of, 30,000 women.